Good morning, everyone. So, today we are going to discuss a topic called drug induced blood disorders. So, what do you mean by drug induced blood disorders? That means because of some drugs, they induces blood disorders that we call it as drug induced blood disorders. So, it is defined as a rare adverse hematological events associated with drug therapy, and it includes four different types. They are aplastic anemia, drug-induced aplastic anemia, drug-induced granulocytosis, drug-induced hemolytic anemia, drug-induced megaloblastic anemia, and drug-induced thrombocytopenia. So these are the different types of drug-induced blood disorders. So coming to this drug-induced aplastic anemia. So, drug-induced aplastic anemia. What do you mean by aplastic anemia? Aplastic anemia is nothing but our body is unable to produce enough red blood cells. That we call it as aplastic anemia. So here, some drugs will induce this inability of production of enough required RBCs. That we call it as drug-induced aplastic anemia. Then coming to pathophysiology, it can be caused by three mechanisms. First is direct dose related drug toxicity, direct or dose related drug toxicity. Second is idiosyncratic mechanism. Third is drug induced autoimmune aplastic anemia. Okay. Direct, that is dose related drug toxicity, idiosyncratic, and drug induced autoimmune aplastic anemia. So these are the different mechanisms. Coming to the clinical manifestations, so direct dose related drug toxicity. That means if the dose of the drug is more, or if the patient is taking the same drug for a longer duration of time, so it causes transient bone marrow failure. So all the red blood cell production will be taking place in the bone marrow. Because of this high dose of this drug, it causes transient bone marrow failure. So depending on the dose escalated, so how much amount of the dose, depending on that, the failure of this bone marrow also will be seen. So it can be caused. What are the drugs that cause direct dose related drug toxicity? That includes chemotherapy drugs and radiotherapy drugs, radiation therapy drugs, which is used for cancer. So these cause transient bone marrow failure. So in that cases, we can see this drug induced aplastic anemia. Then coming to idiosyncratic mechanisms. So here in this case, so the potentiality of the toxicity of the drug increases with few parameters. That includes toxic metabolite of a parent drug. That means when the drug is metabolized, whatever the metabolite it came, that metabolite, if it is toxic, that causes aplastic anemia. So it mainly depends on the metabolite and pharmacokinetic variation among individuals. So why like it will be like ADME will be different for different individuals depending on the pharmacokinetic variations. They are also at risk of getting this drug-induced aplastic anemia. And then genetic polymorphisms. So it causes hypersensitivity of stem cells towards drug or its metabolites. So because of any genetical abnormalities or polymorphism, some people they are at so it's not causing any drug-induced blood disorders in others, but in some conditions like who are having this genetic polymorphism, they are hypersensitive to of these stem cells. What are the stem cells which causes like initial precursor cells which causes the production of red blood cells? So they are highly super sensitive, like hypersensitive to that stem cells towards the drug. Thereby, it causes aplastic anemia. And then drug-induced immune aplastic anemia. So whatever the drug is there, if it activates cells and cytokines of the immune system. So immunes, what are the cells? T lymphocytes and B lymphocytes and cytokines like interleukins. All this gets activated by drug. So when this gets activated, it causes immunological reactions, causing the stem cell destruction. So these are the three mechanisms of how drug-induced aplastic anemia takes place. And coming to clinical manifestations, so the clinical manifestations of this include WBC count very less than 3500 cells per cubic millimeter, low hemoglobin count, as I said that it is aplastic anemia, so the red blood cell count, white blood cell count will be decreased, and fatigue, that is weakness, fever, bleeding, high propensity for infections. propensity, like highly susceptible for getting infections. Why? Because WBC count is less, immune system is compromised, so it is unable to fight against infections. So high risk of getting these infections. And then coming to causative drugs, what are the drugs that causes drug-induced aplastic anemia? It include aspirin, chloroquine, hydrochlorothiazide, chloramphenicol and chlorpromazine. So these are the drugs that causes drug-induced aplastic anemia. Okay. So this is all about drug-induced aplastic anemia. So pathophysiology includes three mechanisms: direct dose-related, idiosyncratic, and drug-induced autoimmune aplastic anemia. In direct dose-related, it depends mainly on the dose, and in idiosyncratic, whatever the toxic metabolite is there, on that it will be dependent, and the other is pharmacokinetic variations among individuals, genetic polymorphism. So these are the reasons for idiosyncratic. And drug induced immunoplastic anemia, here whatever the drug is there, it will activate immune cells and cytokines, that is T lymphocytes, B lymphocytes, and cytokines like interleukins. So when this gets activated, they will start this, they will initiate these immunological reactions. So when these immunological reactions are done, it causes the destruction of stem cells. So these are the mechanisms of drug induced aplastic anemia. And then these are the clinical manifestations, and the causative drugs include aspirin, chloroquine, hydrochlorothiazide, chloramphenicol, and chlorpromazine. And then coming to management, how do we manage this? So first is we have to withdrawal of offending drug which is causing this, and supportive care like symptomatic treatment should be given. Antibiotic, as I said, then they are at high risk of getting infections, so we have to give antibiotics. So it's better to choose this broad spectrum antibiotics. Transfusions, as there is chances of bleeding, so we have, and also decrease in red blood cell count, it is required to give blood transfusions like RBCs and platelet transfusions. And HSCT, that is hematopoietic system stem cell transplantation, as these are causing the stem cell damage, so we can give stem cell transplantation. And apart from all this, yeah, it also includes immunosuppressive therapy. Why? Because immunity is active, immune reactions are taking place. So that is the reason we have to give immunosuppressants. So usually what are the drugs we'll be giving, or anti-thymocyte globulin and cyclosporin are generally used. So what is anti-thymocyte globulin? It's an immune antibodies. So it is derived from horses or rabbits. So it consists of polyclonal IgG and is directed against T cells. So it will release IgG antibodies, and it will direct against the T cells and suppresses these T cells. So the dose of ATG is 40 mg per kg per day for 4 days. And then coming to cyclosporin, what does the cyclosporin do? It will blocks interleukin 2 production. Interleukin 2 is a cytokine which is activated by drug. So it will blocks this interleukin 2 production, thereby it will decreases or reduces T cell activity, thereby it reduces or decreases the the damage of destruction of these stem cells. So the dose of cyclosporin includes 5 mg per kg per day in two divided doses. So this is the dose of cyclosporin. And then coming to corticosteroids. So corticosteroids we have to give in order to prevent the side effects of after using this ATG and cyclosporin. So it is used to reduce the ADRs of ATG therapy. So when ATG therapy is given, at that time we have to meet first, we have to give corticosteroid followed by ATG therapy. So the drugs include methylprednisolone or prednisolone. So the dose of it is like 1 mg per kg per day for 2 to 4 weeks. So this is the dose of corticosteroids. So it has to be given only when ATG therapy is started or initiated. So this is all about drug-induced aplastic anemia. Okay. Now we are going to discuss the second thing, that is drug-induced granulocytosis. So what is drug-induced granulocytosis? Agranulocytosis, that means there is a reduction in the number of mature myeloid cells, that is granulocytes, and immature ones in the body. So this is what will take place, and it is caused due to drugs. That is the reason we call it as drug-induced granulocytosis. So in pathophysiology, here it also occurs by four mechanisms. First is Hampton mechanism. Hampton mechanism, innocent bystander phenomenon. protein carrier mechanism, production of autoantibodies to spoiled membrane. So these are the four different mechanisms. So first we'll discuss the hapten mechanism. So whatever the drug or the drug metabolite is there, it will bind to the surface of neutrophils. So when the drug or metabolite binds to these neutrophils, it forms a complex. Neutrophil and drug or metabolite forms a complex. So this complex, whatever it is, it acts as a hapten. Hapten is what? Hapten is the thing that is a protein that doesn't cause an immune reaction, but once when it binds to any other immune cells or antigen, it causes other antigen. It will have this antigenic properties and it will stimulate this antibody production. So when this drug or metabolite is there, it binds to neutrophils. It acts as a hapten and starts immunological reaction and will start production of antibodies. Okay. So whatever these antibodies that are produced, that will binds to neutrophils, causing the destruction of neutrophils by the activation of complement system and phagocytic system. Okay. And this is caused mainly by high and repeated doses of penicillins. Then coming to innocent bystander phenomenon. So what are the drug is there that binds to drug specific antibody and forms a complex? Drug binds to drug specific antibody. That means it binds to an antibody and forms a complex. So whatever this complex is there, it will binds or absorbs or forms a surface phenomenon and binds to neutrophil membrane. So drug and antibody, this complex is there that will sticks to this stick or absorbs on this neutrophil membrane and also induces antibody production. So whatever these antibodies are produced, that will destroy or destruct these neutrophils by complement and phagocytic systems. So here this is caused by quinidine. Okay, it is just adsorption phenomenon. And then coming to protein carrier mechanism. So whenever the drug is there, it binds to protein carrier and forms a complex. And this whatever this complex is there, protein carrier and drug complex, that will adsorb on the neutral surface and again it will induces antibody production, and once these antibodies are produced, it causes destruction of neutrophils. So this is all about carrier mechanism. And the fourth mechanism is production of autoantibodies to spoiled membrane. So when the drug alters the structure of, so when the drug or when it binds to any other complex with any antibody or protein carrier, or whenever it gets stick to this neutrophil membrane, it causes the damage of this neutrophil membrane. So when this neutrophil membrane is damaged, it will induces the formation of autoantibodies. So whatever these autoantibodies that are produced, that will bind to neutrophils, causing the destruction of neutrophils via phagocytosis. So here the autoantibodies of neutrophils are produced. Here protein carrier and drug will together form a complex. That complex will, when comes and sticks to this neutrophil membrane, it will stimulate the production of antibodies. Here the drug binds to drug specific antibody, forms a complex, when sticks to neutrophil membrane, causes production of antibodies. In all these phenomenon, so neutrophils will be destructed by forming an antigen antibody complex. So the signs and symptoms of it include chills, malaise, increased propensity towards infections, sore throat and fever. So in all these cases, they are at high risk of getting these infections. And then causative drugs include like penicillins like ampicillin, chloramphenicol, hydrochloroquine, gentamicin, captopril, and quinine. So these are the drugs that causes drug-induced granulocytosis. And then coming to management, so in any drug-induced disorders, blood disorders or any others, so whatever the drug or offending drug which is causing these kind of disorders has to be stopped with hold. We have to remove this offending drug from the treatment and then treat infections with antibiotic. As I said that they are at high risk of getting these infections, we have to treat them with antibiotics. Especially it is better to use broad spectrum antibiotics and vigilant hygiene practices as their immune system is compromised. So very proper hygiene practices should be done. Like vigilant means very aggressive or hygiene practices should be done. And then filgrastim 300 mcg per day subcutaneous can be given in order to treat this. And sargrammatism, so it can be given only if the neutrophil count is very much less than 100 cells per mm cube. So at that condition only we have to go for this treatment with sargrammatism or filgrastim. So these are the drugs which we'll be using for treating this drug-induced agranulocytosis. So this is all about drug-induced agranulocytosis and aplastic anemia, and the remaining other kind of drugs induced blood disorders we'll be discussing in the next class. Okay. Thank you all.